Good evening to one and all. Welcome to yet another CCI webinar, Thursday webinar. Greetings from Chess Council of India. I am Dr S Jayaraman. I am the moderator of this today's webinar. I thank Chess Council of India for the opportunity to moderate today's session. I thank the CCI Chairman Trustee, Dr. N. Krishna Sir, Co-Chairman, Dr. Narayana Pradeepa Sir, CCI National President, Dr. Ashish Dubey Sir, CCI National Secretary, Dr. Anil Maske Sir, CCI Webinar Coordinator, Dr. Vijay Kumar Chennam Chetty, and the leaders of CCI and governors of various zones, and the leaders, Dr. Atri Gangopadhyay, Governor of East Zone CCI, and the women leaders, Dr. Kirat Ma'am, Dr. Shivani Swami, and all the leaders behind the screen. They are working 24/7 for the past more than 4 years. This is the 5th year successfully. Every Thursday, it's a different kind of topic, different kind of presenter, moderator, and the speaker from pan-India level, north, south, east, and west. So we are having a wonderful tool to disseminate our knowledge, not only chest medicine, internal medicine, allied sciences. Last Thursday, we had a medical legal aspect of our doctors, how to protect ourselves from the practice consumerism and all. So we had a wonderful, nice platform to disseminate knowledge across India and neighborhood countries also. I thank you all the leaders for this wonderful opportunity to spread across the knowledge. So thank you all the leaders. Good evening to one and all the delegates, those who have joined, log in. So welcome to this Chess Council of India special webinar to commemorate World No Tobacco Day. So Dr. Krishna Sir has chosen the topic such a way that so meticulously they have designed, our architect Dr. Atri Gangopadhyay and other team leaders wonderfully designed. So very, very interesting every Thursday topic. So I thank you, Chess Council of India. So today is, I'll share my screen, PPT presentation. I'll introduce my topic as well as today's esteemed panelist. Is my screen visible? Everyone?
Yes.
Yeah. Yes. Okay. Okay. So today's the topic of presentation in this webinar is to commemorate the World No Tobacco Day. The topic is the challenges of the tobacco products and the strategies to overcome. So in that, we are going to highlight the important 4 points. So Chess Council of India always doing a lot of awareness topics and all. So the public health champion, CCI, is coming to a forefront to raise global awareness about the harmful influences of the tobacco. The second highlighting points is helps you to understand the role of pharmacotherapy and psychological therapy in smoking cessation. The third is the ways and means of protecting children from tobacco industry interference and influences. This is the theme of this year, World No Tobacco Day 2024. And finally, the final highlights will be understand the 5 A's and 5 R's in successful implementation of the tobacco cessation. So this is the topic such a way we are going to discuss in detail with the esteemed panelists. May I introduce the panelists here? May I introduce Dr. Gagan Gunjan. He is an assistant professor of internal medicine in Rajendra Institute of Medical Sciences, Ranchi, Jharkhand, and Joint Secretary of Association of Physicians of India, Jharkhand, and Vice Chairperson of CCDSI, and Assistant Secretary and in GSI, and Organizing Committee member of the EPICON 2025 Kolkata and EPICON 2026 partner. The lot of academic achievements with Dr. Gagan is various national and international publications, author and editor in the textbooks and the peer-reviewed journals, and he has a lot of teaching experience in undergraduate and postgraduate and academic research and workshop in various conferences, national, international, and state conferences. And he has a membership of various professional organizations like API, CCI, and the IACM, etc. So welcome, Dr. Gagan Gunjan. He is a speaker and panelist. Welcome, sir. May I introduce Dr. Avya Bansal, consultant pulmonologist, sleep disorder specialist from, he's working as a consultant in Bombay Hospital and Medical Research Center. He's a honorary pulmonologist in Mumbai Police Hospital, and is having a lung care clinic at Bandra, Mumbai. He received the scholarship during the MBBS time, the Ratan Tata Scholarship, and university topper in MD, ICS ERS Grand Best Paper Award in the Moderator 2019 conference. And he has a 10 national and international publication, and he has a special interest in obstructive airway disease, obstructive sleep apnea, ILD. He set up the adult vaccination OPD at Bombay Hospital. Welcome, Dr. Avya Bansal. May I introduce Dr. Animesh Jain, my friend. He is a professor of community medicine in Kasturba Medical College, Mangaluru, Manipal, India. He is a honorary professor of Indian Medical Association, headquarters New Delhi. He is a sitting committee member of Forum for Ethics Review Committee in India. He is the academic editor of PLAS Global Public Health, faculty of FAMER, mentor supervisor, and the awarded fellowship of Indian Association of Preventive and Social Medicine 2024. The honorary secretary of Indian Medical Association, Mangaluru, and he has a life membership in various associations like IMA and CCI and various forums. So welcome, Dr. Animesh Jain. May I introduce Dr. Sonal Shukla, MD, consultant psychiatrist. He is working in Manavchar, Postgraduate Institute of Behavioral and Medical Sciences, Raipur. Madam is a Life Fellow of Indian Psychiatric Society, Life Fellow of Indian Psychiatric Society of Central Zone, Life Member of Geriatric Psychiatric Society, and Member of American Psychiatric Society. Welcome, Dr. Sonal ji. Last but not the least, Dr. Anirudh Saini, MBBS, DTCD, DNB. He is a consultant pulmonologist working in Metromas Hospital, Jaipur. His areas of interest are interventional pulmonology, allergy, asthma, and immunology. Welcome, Dr. Anil Saini from Pink City, Rajasthan. Thank you. So with this, we'll move on to the presentation. The flow of the event will be, there are two PowerPoint presentations. The first presentation from Dr. Gagan, followed by Dr. Sonal ji will present. So we have two interesting topics. The first topic, Gagan is going to talk on science behind the tobacco addiction and how to going to overcome it. Followed by Dr. Sonalji will speak on role of psychosocial support in management of tobacco cessation. Now over to Dr. Gagan Gunjan.
Good evening all, and welcome to the Chess Council of India webinar today on no smoking. I'm really thankful to Chess Council of India today for giving me this opportunity to speak on this topic and reach out to such a large family. So the topic given to me today by CCI is science behind the tobacco addiction and how to overcome it. To introduce you with the topic, all of us know tobacco dependence is defined as an acute illness and a serious public health concern, and hence the treatment and public awareness of this tobacco dependence is important for all of us. What is the primary addicting substance in the tobacco? The main primary addicting substance in the tobacco is nicotine. This nicotine is an alkaloid that is naturally produced and is considered to be a primary addictive agent that makes people addicted to it. It is a highly active substance and it influences the brain and creates dependence in several ways. So how does it act? Basically, its actions are mediated through nicotinic acetylcholine receptors located on the neurons in the brain and other organs. And mainly, this elicits the production of different neurotransmitters, that is mainly dopamine. And this is this dopamine that is related to the feelings of pleasure, reward, and conditioning of addictive behaviors. This also influences systems, provoking increased tone and tension of blood vessels, and also causes tachycardia along with other various physiological effects. The mechanism mainly involves formation of several neurobiological risks, which includes mainly nicotine tolerance, physical dependence on the substance, and withdrawal symptoms. The most important neurobiological system involved in the brain is the brain reward system. Now, what we mean by this brain reward system, especially this is a mesolimbic dopamine system involvement. It said its involvement and in conditioning, proximal environmental stimuli and stress also plays a great role in all of this. So if you look at the major brain areas that are associated with nicotine addiction, this mainly includes prefrontal cortex and ventral tegmental area, along with nucleus accumbens. Can genetic factors cause nicotine addiction? Yes, the answer is yes. Another fact about addiction is that it is genetic and certain levels of risk depend on the family genes for an individual to become an addict. Several genes have been found to play a role in the metabolism of nicotine at the dopaminergic system, as well as the nicotine acetylcholinergic receptors, where the activity contributes to the tendency of an individual to get addicted to nicotine. Social factors too have an important role in the addiction formation, and this includes peer influence, pressure, stress, and tobacco products all have an impact on this use of tobacco and dependency. Certain factors that are commonly seen are peer pressure, smoking myth, smoking as a fun, unpleasant event in person's life, or smoking replaces certain some form of addictive component. So how do we see this? Social requirements and forms, advertising, availability, all have an impact on the use of tobacco. Some people start with the use of fun and friendship, but then this goes on to develop nicotine cravings. And once these nicotine cravings develop, and then you want to stop the this nicotine craving, then you have certain signs and symptoms of nicotine withdrawal. Now, what are these? These signs may include something like irritability, difficulty in concentration, increased appetite, hunger pangs, sleep disorders, weight gains, and then you all have those recent complications of the physiological and social behavioral complications also. Health consequences you cannot ignore. Tobacco dependency results in various health consequences like various types of cancer. It raises overall cancer risk in almost everywhere in the body. Take any part of the body and you will find tobacco or nicotine affecting your health. It is one of the main causes of mortality and morbidity that is related to several risks and cannot be easily eliminated unless you take a pledge to leave or to quit tobacco. So what are the approaches that can be thought of overcoming this tobacco addiction? Managing tobacco dependence, which in this case means stopping the use of this substance, trying to quit the nicotine addiction. So cognitive behavioral therapy stands the first line of choice for any person or any counselor to asking the person to quit tobacco. So what you can do is that according to the best range of medical treatments, along with pharmacological therapies such as nicotine replacement therapy and drug therapy, behavior modification interventions like individual counseling and can also be implemented. Or you can, whenever you have a very intense desire of craving, what you can do is take a deep breath, have some water, call a friend to distract yourself, choose some healthy snacks to divert your mind, and do some sort of meditation to fight that impulsive form of craving that you're having at that moment. An efficient way of making smokers quit has been developed, and this is known as nicotine replacement therapy. This delivers nicotine to the body without the other toxic substances that are present in the cigarette smoke. This can be in the form of nicotine skin patch, nicotine gums, nicotine lozenges, or nicotine nasal spray. If we look at the pharmacological therapy, then we have mainly two drugs, bupropion and varenicline. Bupropion is an antidepressant that has been known to help smokers quit smoking, and varenicline is also specifically formulated to assist individuals to quit smoking. Pharmacological treatments like medications, nicotine replacement therapy, and combinations can be of great help in counsel along with a behavioral counsel therapy for motivating a person to quit tobacco or smoking. Physicians have a great role to play or to motivate the society in quitting tobacco. They are crucial parts of the general patient care and have important preventive measures and can take important preventive measures to control or to quit this tobacco from the society. This can be done through proper counseling, proper intervention, and right and timely prescription of the certain drugs along with behavioral therapy that can be of great help to the mass and the society. There are certain alternative therapies also, Ayurveda, meditation, acupuncture, yoga, but scientifically these are less documented and more literature or research is needed on this part. Secondhand smoke is another especially that is considered to be deadly to non-smokers. This increases their likelihood of contracting lung cancer along with other cancers also. So this secondhand exposure should be minimized to maximum by using public free zones where smoking is not allowed, or public free or smoke free places in a public scale, in a public background. We need to focus on overall measures for reduction of tobacco consumption. Comprehensive international cooperation along with the WHO and Indian health guidelines with evidence-based practices need to be taken care of in formulating all these efforts for the public and offering suggestion, support and campaigns to the public for quitting tobacco and nicotine. This can be in the form of conducting awareness programs, adopting a clear-cut policy, excluding tobacco industry as a stakeholder, informing and educating the population, and also forming public free zones and rehabilitation center for certain group of populations. Still, challenges are great for making the quitting tobacco propaganda be a very good and successful. Challenges remains there. This can be taken in the form of thoughts, behaviors, emotion, and certain psychosocial support, which will be taken up with my subsequent speaker, Dr. Sonal, in the coming session. So to conclude with this, it is quitting tobacco is often considered to be a challenging task for everyone, and we should design certain specific health guidelines along with public campaigns and education to control this, meeting people's needs, promoting prevention, and developing and implementing cutting-edge effective public health interventions are the need of time. That's all. Thank you. Thank you so much.
Hello everyone, I am Dr. Shukla from Consultant Psychiatrist and Faculty from Postgraduate Institute of Behavior and Medical Sciences, Raipur, and have a clinical experience in psychiatry for more than 15 years. And thanks for making me the panelist in this session of World Tobacco Day. And I would be discussing the role of psychosocial support and pharmacological intervention in the cessation of smoking. So basically, rest of the part like nicotine, types of nicotine would be covered by the other panelists, and I would be going ahead with the psychosocial and pharmacological intervention. So smoking cessation overview, if you see there, that is why is it important for quitting smoking, what are the health benefits after the cessation, and challenges faced by the individual who are trying to quit. So psychosocial support in smoking cessation is the most important thing we as a psychiatrist know, because it involves the total support social system of an individual who try to quit smoking. Type of support include individual counseling, group therapy, and support group as well. So impact of psychosocial support are effectiveness, which enhances the motivation and coping skills, reduces the relapse rate. Mechanism involved are addressing the behavior and emotional aspect of the addiction and providing a full support network to the person who is trying to quit. Now comes to the pharmacological intervention. The purpose of pharmacological intervention is aid in reducing the withdrawal symptom and cravings, and main therapy which are involved are nicotine replacement therapy and bupropion and vernicillin, though clonidine also has got some role. Form of nicotine replacement therapy which are available in India as well as abroad are patches, gums, lozenges, nasal spray, and inhalers. The benefits include that it reduces the overall withdrawal symptom of the nicotine, gradual reduction in the nicotine dependence by replacing them with patches or gum or lozenges, and usage guideline is that it should be properly dosage and correct dosing should be required, and combination therapy should also be required. So as you can see, there are gums and lozenges available. Lozenges being more effective than the gums, by my clinical experience, is that it has to be chewed slowly, and when you should be clearly explaining the patient to stop chewing when it appears tingly, like he's keeping here. Then he will park the gum in the buccal mucosa and then chew again when the tingling fades, so that the gradual release in nicotine, which help in the withdrawal symptom per se. They are available in 2 to 4 milligram dosages, and if he's smoking more than half a packet of cigarette, then 4 mg is required, and if less than half packet of cigarette, then 2 mg BT dose is sufficient. And no food and drinking should be allowed 15 minutes before the usage, and nicotine is absorbed to the lining of the mouth. So you, after like, not like jelly ki, if you swallow it, it should be kept in the mouth buccal mucosa itself. Then 2 forms, if combined together, is more effective, like patches as well as lozenges, like they are more effective, found to be more effective. Then comes the bupropion, which is basically an antidepressant. We psychiatrists have used more for the nicotine replacement as well as, and it also elevates the mood. So it helps in both the thing. Like the patient who is depressed are more prone to having this smoking as a form of anxiety reducing thing. So bupropion will help them to stop the craving as well. Plus also it will help them to both the thing. Depression mood is also elevated. So how it acts? It acts as a neurotransmitter in brain. It works in the biology of brain in nicotine addiction by enhancing dopamine level in the reward pathway, affect noradrenergic neuron in the locus coeruleus to reduce the craving and the withdrawal symptoms. So this is very important, like noradrenergic neuron, it will help them to reduce the craving. So this is how it is helping them to reduce craving. Typically it is prescribed as a 12-week course we give. We start with 150 milligram BD for 2 weeks, and then gradually shift them to even to 300 milligram if required. And maintenance dose is 4 to 6 weeks of giving bupropion. So a possible side effect which the patient will report will be insomnia, dry mouth and headaches, but this is not so much. You can ask them to also take it with lozenges. You can combine so that the effect of dry mouth will go. Then vermicelline is also very good nowadays. It is responding. Patients are responding. My patients are also coming back for this vermicelline, and they are not smoking since last 6 to 8 months. So it is a partial agonist of the nicotinic receptors. This is the main. So it reduces the craving and decrease pleasurable activity of the smoking. Usually it is a 12-week course, and possible side effect include nausea, vivid dreams also sometime, and mood changes. So we have to be careful regarding that. Then vermicelline dosage are like treatment plan, which usually is of 12 weeks, and additional of 12 weeks for the treatment may be considered for the patient who are successfully quit at the end of the 12 weeks, considered successful. Okay, and then vermicelline is supplied for oral administration in 2 strength, that is 0.5 mg and 1 mg. Titration is as below. You can see how it is titrated. Then comes the management and counseling part, which is important for all the psychiatrists and also for, I think, the chest people as well, because they usually come in relapse to you. So evaluating the whole smoking situation in the form of like cognitive behavioral therapy, motivational intervention therapy, and stress management technique. So as you all know, the smoking cessation, there are 5 A's and 5 R's also. So 5A, we are talking about asking about smoking, advise every smoker to stop smoking, assess the readiness, whether they are ready to quit, and assess the smoker in stopping smoking, and arrange for the follow-up and monitor the progress of the smoker. And 5 stages of changes are also very important, like they are pre-contemplation stages and contemplation, determination, action, and maintenance stages. And 5 are all, as you all know, are the relevance, risk, reward, roadblocks, and repetition. So these are smoking cessation strategies for a psychotherapist. We generally refer them to therapists for that. So in very short, I'll explain what is pre-contemplation. It is a state that the patient is not ready to quit. Then comes the contemplation stage, when the patient is considering smoking cessation at some point in future, not completely. So determination is whether is actually determined, actively considering determined or not, then action taken by the patient will be the fourth point, that is whether he is actively involved in quitting smoking or not, and maintenance, which is that the patient has quit for last 6 months. So I think it is clear. Then comes the relapse. So relapse is very common in after smoking. So we should be considering how to prevent relapse. So designed to prevent smoker from turning into smoking behavior again. So we avoid the minimizing the exposure like stress and smoking. Like if the patient is already stressed, his work hour is more. If there is any professional burnout, is more prone to again go to the smoking part. If his sleep and appetite should also be taken care of. And if he has some panic anxiety issue or any problem with the boss or with the senior authority, then also they relapse. So coping strategy which are involved in prevention of relapse are techniques such as deep breathing or relaxation tape to deal with the withdrawal symptom. Contingency management is of course very important to relapse, which involves rewards also, rewarding them for if they are not doing it, and some kind of punishment, not like beating per se, that is not punishment in psychiatry, it's like punishment. So nicotine fading. Nicotine fading is gradual reduction of nicotine intake. It is very important. Tapering the number of the smoking cigarette smoke and switching to the brand which has got less nicotine. There are few brands, but disadvantage is that they will be inhaling more and more longer to get the same effect of nicotine. So this is also a type of, so now comes the integrated psycho and pharmacological approach, which I started with. So it combines both strategy for the great success, personalized treatment plan depending upon the comfort of the patient, continuous support like follow-up session, and follow-up session we even advise the wife or the caregiver or immediate parents to come. Sometimes the father mother doesn't even know about them, they have a very strong reaction when they the child say that he is smoking for 1 year. So any reaction formation should also be discouraged. Monitoring progress and adjusting the treatment as well. Importance, summarize, I'll do that it is a holistic approach, increases the success rate, means everything together. Call on action will be encourage individual to seek help and support for smoking cessation. So I think I have cleared most of the things which was being expected from me. If there is anything left, please let me know. Thank you so much.
And clarity presentation by Dr. Gagan and Dr. Sonal for the wonderful talk about the science behind tobacco and tobacco addiction, and the psychosocial and pharmacotherapy by Dr. Sonal. So very fantastic, wonderful presentation about the tobacco and all. So thank you. So we'll move on to the panel discussion. Thank you, ma'am. Welcome. So we'll move on to the panel discussion. So you all know very well that today's topic around the tobacco, to commemorate World No Tobacco Day. So this year theme is very clear that protection of children from the tobacco industry interference and influences. So children means you all know very well about that, the age groups starting from the 10 years to 18 years. Children up to 18 years, we call it children only. This is the teenage and adolescence age. So this is the time, very, very important, crucial period. So all the bad habits and all, so we'll be careful as a family member, as in the social, the school, college level. It's a very, very important thing. So we'll start with the basics and beyond about the tobacco and tobacco products and tobacco cessation treatment, etc. So we'll begin the questions first with may call Dr. Avya Bansal. Bansal, this is a question for you. Yes, basic about the tobacco. What is tobacco and what are the chemicals in this tobacco? Yeah,
yes, sir. Thank you, sir. So tobacco is a plant, and the leaves of the plant are cured, and tobacco is used in various forms, whether it's a inhalation product or an oral product. So it basically comes from a plant with 70 different types of species known as Nicotiana. So that's the origin of the tobacco plant. It's been there for thousands of years, and over the period of time, the use has only grown and the misuse has grown even further. The potential chemicals in tobacco and tobacco smoke are more than 4,000. We can go from A to Z in talking about the chemicals in tobacco. The addictive substances are the alkaloids, which is nicotine and harmala. These are the addictive substances which form the basis of tobacco addiction, known as the alkaloids. And the harmful substances are far more, right from arsenic to polycyclic aromatic hydrocarbons, benzene, naphthalene, cadmium. These are all harmful chemicals which are used in various industries to kill rodents, sterilizers, and these form the basic products and aspects of the contents of the chemicals in tobacco. So we can understand how toxic this tobacco fume, tobacco smoke, and tobacco oral consumption is, because we are using the products in tobacco in various chemical industries and in toxic product industries. So yeah, that's the content of tobacco and its chemicals.
Very nice explanation about the tobacco and the chemicals present in the tobacco. Tobacco basically in the leaf, it leaves. The tobacco leaf contains a lot of chemical substances. As per the statistics, more than 4,000 chemicals present in it. And in the 4,000 chemicals, the more than 70 chemicals are carcinogens, that is cancer-producing substances, and a lot of toxins. And it affects all the system from head to foot. Yes, thank you, Bansal. And we'll move on to Dr. Animesh. Animesh, there are a lot of tobacco types. So what are the types of tobacco usages in practice? Tobacco, types of tobacco. Over to Animesh Jain.
Thank you, sir. I hope I'm audible.
Audible, yes.
So very simply, if I put, we can classify this into smoking and smokeless. Okay. So if I have to talk about smoking, we know that smoking type would be the cigarette, the commonly used. And in India, we find that BD. So BD is there, which doesn't have any filter. It's not manufactured, but it's more of that, the tendu leaf, which is rolled in, and then there is tobacco inside. Then there is cigarette, as I said. Then, of course, there are more sophisticated forms like cigar or pipe. And then we also have the traditional, which has been in some parts of our country, as well as in Middle East and all, we find the hookah or the water pipe. Okay, so that's been there. And some of the times we see that there are some, posh clubs and pubs and all which popularize this. And other than that, sir, there is also one form which I have actually seen when I was there in the hostel and all. There is roll your own. So that is, as a kit, is available, which is not very popular in our part of the world, but it's been there in Europe and some other parts of the world. But that's also there. The danger with that is that there is much more harmful effect, because it's the person who's smoking will prepare that using very simple way of rolling it within that paper. Coming to the smokeless, now we have the common ones which are there in some parts of India, in some eastern part as well as northern part of India, the snuff, and also chewable one. The chewable tobacco, which is kept as a bowl, a quid kind of a thing, which is kept between the cheek and the gums, or in the front part of the mouth. So that is there. Other than that, I want to mention about, there is, of course, we would have heard the announcement when that is made in the flights, that e-cigarette use is not permitted. So that's been there, but now in our country, at least in flights, it's not permitted. It's illegal. So e-cigarette is there. The difference between that is that in most of the ones which I talked about, the smoking form, smoke is inhaled and taken in. But in this, what happens is that is atomized, and then there is a vape. That's why the vapor is there. And that's why it's also known as vaping, because there is a tank or there is a kind of a reservoir which is atomized by the device, and that gets inhaled inside. So that is another one, and it is much more dangerous as well. It seems to be fashionable, it seems to be less harmful, an alternative or something, but these are some of the ways which we can inhale or which we can take in tobacco, to keep it very simple. Thank you.
Thank you very much for this wonderful answer about the types of tobacco. So smoking tobacco and smokeless tobacco. So smoking tobacco is very common, BD, cigarettes and all, hookah and all. Smokeless tobacco, mainly the form of chewing tobaccos. Chewing tobaccos, a lot of things, pan masala, jarda, gutka, a lot of things which contains nicotine and other chemicals. And the snuff powder inhalation through nose is also another thing, and application. Some powders and for the toothache and other thing they apply in generally in the rural areas and suburban areas. They used to have a lot of things. So smoking tobacco and smokeless tobacco. So in Indian scenario, so what do you think? Which is the more chewing tobacco is more prevalent, or is it smoking tobacco is more common in our country, mainly the urban and suburban and rural areas? Animesh?
So as far as I understand, smoking is more prevalent because smoking, even that BD and other, if you take combined, that what you talked about, the snuff and the what we say that khaini and gutka, that is also there, but the smoking one is much more prevalent as far as I understand.
Yes, I fully agree. Thank you, Animesh, for this wonderful answer. And we'll move on to Dr. Sonal ji. You explained all detail about during your presentation about the substances, what are the substances causing addiction mechanism, etc. And again, for the audience sake, what are the addictive substances in the tobacco? Sonal ji.
So, good evening, everyone. In nicotine, of course, the tobacco, nicotine itself is the most addicting type because it acts on the nicotinic acetylcholinesterase inhibitor, and which lead to the release of like acetylcholine, which helps them to getting more and more dependent, because initially it will cause more clarity, increase concentration, attention span, everything. And gradually it leads to then dependence on the nicotine, and also it acts on the dopaminergic and noradrenergic neuron to increase its concentration. So nicotine per se is the most addicting thing in the tobacco. Yeah.
Yes, Sonal, thank you.
Yes,
Apart from nicotine, what are the other addictive substances? I think Dr. Gagan during presentation mentioned about some alkaline and other chemicals or addiction, but nicotine is the prime addictive substances in the tobacco. What are the other substances you come across in your practice?
Like apart from nicotine, or you like
only like, substance is nicotine, or any other substance can cause the addiction, like alkaloid, something that the Gagan told now.
Yes. If it is taken in the form of there are various forms, like in our, especially when I witness Chhattisgarh population and Central India population, they take they take it in form of gudaku, which is very common here, and more prevalent like gudaku in the female population of Chhattisgarh rather than male population. So they use it as a dant manjan, and the reason they give is before, without that we cannot go. Our bowel movements are not clear. So they become more and more dependent. Also, male also, and more like in Corona, especially there was a high withdrawal which I noticed in most of the population, because that was also not on sale. It's a small dibbi we get in this Chhattisgarh and Madhya Pradesh region, and also I think in some part of Jharkhand and Bihar as well. So that is there. And then here like pan masala, mixing them with bidi patti is very common. And they keep it here, like as he said, Dr. Animesh, keep near here or here somewhere. And most of the psychiatry patients, they're already chewing that and coming to me with anxiety. And they ask me they want to leave, but as such, there is no active, and also cannabis, of course, is very, very common, which I have noticed here. So they also mix some cannabinoids along with this also. Both together also they smoke. So, of course, marijuana, cannabis will also increase all their delusion, hallucinations as well here.
Thank you, Sonal. You mentioned about the nicotine and other cannabinoids, alkaloids, etc. in the tobacco addictive substances. Thank you. So we'll come to Dr. Anirudh. Anirudh, the question is, what are the smoke inhalation, types of smoking inhalation? There is a inhalation like active, passive, or first and second and third hand. So what is your, can you throw some light on first hand smoking, second hand and third hand like this? Yeah, Anirudh.
So I think earlier somebody discussed this. The first hand smoking is what everybody knows it like that. It's the smoke inhaled directly by the person who is using the tobacco product. So it can come from various sources like cigarettes, cigars, pipes, vaping devices, hookahs, and more commonly from bidi, chillam, and hookah in India. So it is the first hand smokes. The another one is the second hand smoke. Second hand smoke is a combination of two things. So it comes. It first is the it comes from the smoke which is coming out of the lungs of the patient when he exhales, who is using the tobacco product, and also some of the smoke that which drifts from the tobacco product that is burning. So this is the combination of two things. Okay, so this secondhand smoke, it goes in inhalation lungs of the those people who are actually non-smokers. So it affects them also. So we are not safe. I mean, any person is not safe if he is not directly smoking, but if he is in contact of other smokers. So the secondhand smoke can uh, create some detrimental effects on the health of the bystander, non-smoking bystanders also. And there is another third type of smoke that is called third hand smoke, which is produced when the dust, when these type of first hand smoke and second hand smoke, when they settle onto the surface and objects, then the thing that is produced, this residue, which consists of a lot of toxins, is produced. So it is called third hand smoke. It can affect people in many ways. Like it can come directly into contact with our skin. So on objects, it may settle on objects like walls, floorings, carpets, clothes, linens, beddings, and objects, and even on the toys which children are using. So it can like directly sometimes come into contact with the skin also, and can cause damage if it is being coming in contact over a long period of time. And also when the dust, this residual dust wafts into the air, and then somebody else can inhale them. Also it can go inside our digestive tract if some we are using some contaminated food object, or children, like children, they are, if they are putting things or their toys inside their mouth, then it can go into the digestive tract and directly enter the bloodstream. So it contains a lot of toxins, nicotine, and carcinogens, and also heavy metals like arsenic and something. So it's like these forms which I know about types of
Very
smoke.
good. Very nice. You describe in detail about the first-hand smoking or active smoking, second-hand or passive smoking, and third-hand smoking. The walls and the cloths and the tables, a lot of particles. Third person came into the room. That inhalation leads to a lot of issues, health issues. Third-hand smoke. Very nicely elaborated. Thank you, Anirudh. I'll move on to Dr. Gagan ji.
Yes, sir.
I think that Animesh touch upon this topic slightly, so you can elaborate on that. What is vaping? Vapor, that is electronic cigarettes. Can you throw some light on electronic cigarettes? Majority of the a patient come in, doctor, can I take the instead of regular cigarette, can I take the electronic cigarette, doctor? They're asking somebody. So what is your take on this vaping or electronic cigarettes? Gaganji.
Yeah. Sir, actually, vaping or e-cigarette is a device that stimulates is tobacco smoking. So if you look at the composition of these devices, mainly it consists of an atomizer, then we have a power source battery, and then we have a cartridge or ink. That is what it's called. So instead of smoke, this patient or the user inhales vapor. So what the atomizer does, atomizer is the heating element over here that vaporizes the liquid or e-liquid into tiny droplets. And the patient inhales this tiny droplet. This is the act of vaping actually. So the further patient or the person or the user can modify it according to his own by adding certain flavors to it. In no way, vaping or e-cigarette is considered safer. It is less toxic than cigarette, but it is still not considered safer, and it can lead to consequences of several diseases like asthma and COPD and other respiratory diseases to it. So in no way it is recommended, and this use of all these electronic devices, the device or process is basically vaping, what we call.
Thank you, Gagan, for the wonderful explanation about the wrapping on the electronic cigarettes. So thank you very much. So the audience knows clearly about that. I request all the delegates kindly post your questions related with this tobacco and tobacco products or treatment aspect, pharmacotherapy and psychotherapy, etc. Thank you. So very nice. Our chairman, Dr. Krishna sir, put up the message. Congratulations, President Tom. There are, as of now, there is 1,058 logins now. So long live CCI. Thank you all for this wonderful effort for this.
That's
Thank
great,
you.
sir.
Yeah, great number. Nice. Thank you, Krishna, all your dream project. So we are applying here. Thank you, sir. So we'll move on to the next questions to Dr. Animesh Jain. Animesh, tobacco initially came as medical purposes. Later on, because of a lot of addictive substances, which indulge into various system fault. So, what are the health hazards of smoking? What Dr. Animesh saying? Health hazards of smoking.
Thank you, sir. I think most of the people would be familiar with certain few things, and now that we have that pictorial warnings, so we all know that tobacco smoking definitely causes cancer. So it does cause the cancer for most of the people. They know that it's lung cancer is caused, but also oral cancer, and then throat cancer. And other than that, many other parts of the body, they can be affected, and it can cause cancer almost everywhere, of the larynx, of the stomach, of kidney, even colon, rectum. So, it causes, and even leukemia has been linked with the tobacco use. But other than that, we know that respiratory diseases, especially chronic obstructive pulmonary diseases, can be caused. Emphysema is one of the things which is very closely related with chronic use of tobacco, and especially smoking. So that has been there. But I also want to draw your attention to the fact that tobacco smoking itself is a risk factor for many other diseases. And especially when we talk to our students, undergraduate students, we tell them about risk factors. So one of the common risk factors for many of the non-communicable diseases is tobacco, whether it's in the form of smoking or any other form. So cardiovascular diseases, hypertension, stroke, so many things, including diabetes. In fact, diabetes, it is said that, and in India is supposed to, of course, the date is delayed, but India is supposed to have one of the maximum number of diabetics in the world, diabetes capital of the world. So diabetes, in fact, they say that 30 to 40% higher chance of developing diabetes is there in active smokers compared to non-smokers. So that is there. Other than that, it can also lead to especially in women, and we have seen, especially in this area, some parts of Karnataka, we have these beedi rolling habits. The women folk at home, in their spare time, they actually roll beedis. So what happens is, they may themselves not consume it at times, but what happens, since they're doing it for a large part of the day, so there is some part of this dust which gets into their respiratory system, and it also goes in through the, it's like through the skin also it gets in, and cutaneous absorption is there. So all these also lead to a lot of problems, including the fertility issues, and then in women, especially when I'm talking about. So what happens is, there are miscarriages, there are abortions which happen. So that happens. And in men folk, we also see that there is fertility issue, that sperm motility is decreased. So these are some of the things which are also part of tobacco, which people sometimes don't relate to or don't think about. And other than that, there could be, like, as I said, in women, if they are exposed to, or they have a habit of smoking, or they consume tobacco, so they also lead to stillbirth or preterm delivery or low birth weight, or sometimes, though not very common, but sudden infant death syndrome may also be there. And what is also seen, since I'm talking about women, so women, what also happens is, sometimes we have seen that women who are of that childbearing age and who have been smoking for some time, so they usually have a weaker bone. So their bones are weaker compared to people who are not, the women who are not smoking. So again, there is a higher chance of, they are more fragile. So the chances of having a fracture with a smaller fall and all also is there. And yeah, one thing I forgot is, for people who smoke especially, and even for those who keep a canny or a quid or something, so for them, again, the oral health issues are there. and many times they have gum diseases as well as the dentition, and some of the people also report having the tooth loss. So these are some of the things which you can see that a gamut of things which are there, which are affected because of this smoking.
Thank you, Animesh, for this wonderful explanation about the health hazards of smoking. So it affects the head to foot in all the organs: cancer, heart attack, stroke, and thrombosis, abdominals, infertility.
Yeah.
There's a lot of sexual dysfunctions and infertility issues. Head to foot, all the problem. So we go to the cinema hall. Usually, the first slide, usually before screening the main movie, they display smoking is injurious to health. Smoking causes cancer. Smoking kills. So after seeing the advertisement during the intermission period, a lot of people going and having a lot of smoke and other thing and all. So the advertisement part, I don't think it's a very implementation or very poor. Where we lagging behind, I do not know. So we'll come to later that part of discussion. Thank you, Animesh, for this wonderful explanation about that. So coming to the question to Dr. Gaganji. So cigarette and BD, this is a smoking commonly we are used in urban, semi-urban, city area and all. So which one is more harmful? Both are harmful only. Which is quantity-wise, chemical-wise, toxin-wise, nicotine-wise, which is more dangerous, whether BD or cigarettes?
Yeah. Sir, actually, if we compare BDs and cigarettes, both are quite popular in both rural and urban area population of the India. But BDs are considered to be almost 8 times more harmful as compared to cigarettes. They have a higher content of nicotine. They have no filters, and they also don't have any lining of filters to filter off the certain carcinogens. And also they have a great combustibility and a greater inhalation puff that is required for taking BD smoke inside. And this is the main factor that is creating more damage to the lungs and other organs of the part. So BDs are no doubt considered to be very harmful. They contain almost 21.7 gram of nicotine, 7 milligram of nicotine per gram, as compared to 17.6 milligram per gram of nicotine in cigarettes. Also, if you look at the carbon monoxide that is accumulated, that is more in BD as compared to that. So if you consider pre-op postponement of smoking for the pre-op postponement requirement, then you need a longer abstinence period for BD as compared to cigarette. It is 24 hours for BD as compared to 6 hours for cigarette. So BDs are definitely dangerous and more harmful as compared to cigarettes.
Yeah, thank you. So the paper from the Delhi, called in Chandigarh PGI, there is Dr. Digambar Behera, one of the former president of ICS, Indian Society. He had a paper presentation on this thing, because he is the president of the Lung Cancer Association of India. He did the largest clinical trial and other things about which is more harm. This is a cigarette or BD. So the conclusion that BD has more toxic substances, mainly the nicotine and other thing, and BD has no filter, and the cigarette has filter effect. So BD is more harmful than the cigarette. The study concluded that whichever the form of tobacco smoke is injurious to health, BD is more. Because in our India, in Indian population, majority of them, the villages, lot of villages, they have the BD smoking. So very common when compared to the cigarette smoking and all. So BD is more harmful than the cigarettes. Thank you, Gaganji, for this wonderful explanation about that. So coming to Dr. Avya Bansal, there is a question about the chewing tobacco and oral cancer. Because in India, if you take the cancer incidence, the oral cancer is the number 1 cancer. Oral and head and neck cancer is the number 1 cancer in Indian populations. So in female population, next to CA breast and CA cervix, oral cancer is very common. And in the male population, oral head and neck cancer is the first one, and the second is lung cancer. So what is your take on this? How the chewing tobacco and oral cancer? Bansal.
So, sir, chewing tobacco is directly linked to oral cancer. I think almost 50% of all oral cancer is related to consumption of tobacco in the oral form, followed by cigarette smoking, alcohol consumption, poor oral hygiene. But all data says that about 40 to 50% of all oral cancer is directly related to chewing tobacco. Now, chewing tobacco can be in various forms, whether it's gutka, zarda, kheni, you get in various ways, or just simple betel quid also with tobacco, which is kept inside the mouth. There's obviously a submucosal absorption, which causes some erosion changes. Over a period of time, there is dysplasia in the form of leukoplakia, which leads to erythroplakia. And these are all pre-malignant lesions with time which become metaplastic and cause malignancy. So this is directly linked to direct consumption of oral tobacco. As far as the incidence is concerned about, I think oral cancer is 20 to 30 per 1 lakh population. I think Dr. Animesh Jain would be the ideal person to talk about it. But that's what I remember from reading quite some time back, that this is the most common incidence of oral cancer. Now, if you look at the incidence of oral cancer, there is buccal mucosa, which is the most common presentation in my part of the country, as well as in the north. But if you look at the south and in the east, you've got more tongue cancer as compared to buccal mucosa cancer. This is just an incidence which is there. Also, the male to female ratio is almost equal in Maharashtra, whereas if you look at the South India, you've got a male predominance as compared to a female predominance. This could also be linked to the number of people consuming oral tobacco. And a funny statistic tells us that almost 50 to 60% of adult men consume tobacco in some form, and about 20 to 30% of adult women consume tobacco in some form. So these are alarming numbers when we look at the Indian population of 1.4 billion, that almost 50% men and 20% women are consuming tobacco in some form or the other during the course of their lifetime. So very, very high risk of malignancy, and the future is not so good with respect to tobacco consumption.
Thank you, Bansal, for this wonderful insight about the chewing tobacco and the oral cancers, predominantly the tongue cancer and buccal mucosal cancers. In South India, in our place, we are seeing most of the cases of tongue cancer because of the betel nut chewing and tobacco chewing habits here. So this is the main culprit behind it. Thank you, Bansal. So I will move on to Dr. Anirudh. The question is about the tobacco smoke and lung cancer screening. So if you take lung cancer incidence in the world scenario, lung cancer is the #1 cancer among the cancers. So the risk factor in Western world predominantly is the smoking. Smoking is the main culprit. But India is slightly different. The smoking, tobacco smoke, as well as the air pollution plays a major role causing the lung cancer as well as the COPD. So can you throw some light on the tobacco smoke and lung cancer screening program in India and Western, whichever the come? Yeah.
Regarding this lung cancer and smoking association and the screening of it, so the American Thoracic, what I have learned is that American Thoracic Society has recommended regular screening for those who are considered at high risk according to their criteria. So their criteria is like any person who is from age 55 to 80 years of age who is a current smoker, or 55 to 80 years of age who has quit within the last 15 years after smoking 30 pack years history of cigarette. So that is their criteria, and so these are they are the eligible. So high risk people are eligible for lung cancer screening. So it's like lung cancer screening has three parts. So first is who should be screened, and how often should they be screened, and for how long they should be screened. Second part consists of the maintaining all the records of the patient, all the subjects who have been screened for future use, and third part is implementation. So regarding who is eligible, we have already discussed as per their ATS criteria. So and regarding the implementation of this lung cancer screening, so we have to depend on we have to educate the primary care physicians, the PCPs, the referring clinicians, who generally the first of all the patient comes in their contact. So if they meet the eligibility criteria, then they have to be sent to the higher center for screening. And so for that, we have to educate or train a lot of general practitioners, and they will then send the patient. And another thing is that they have again their electronic medical records have to be maintained. Generally in Western countries, they are maintaining electronic patient records. So an alarm system which is installed in this electronic patient records, it can be very useful, prompt which will give that the patient is fulfilling the criteria, eligibility criteria for screening. And the third is the patient has to be then the CT chest scan has to be done. So a low dose CT chest as per the structured protocol of radiology, it's called lung rats, that has to be done. So again, for that, the CT scan technicians have to be trained and educated, and radiologists have also to be trained to use that system, structured lung rats system. And those once the subject is screened, and there are some general practitioners who are repeatedly sending some patients who are actually not eligible for the screening. They have to be given the feedback. We have to be in their contact, and we have to constantly give them feedback that no, your patients are not meeting eligibility again and again. So you have to follow the criteria more strictly. And this is like what I learned from the ATS guidelines. And other which is useful guideline is NCCN, National Cancer Comprehensive Network. So their criteria is if the patient is equal or greater than 50 years of age and has more than 20 years of more than 20 pack years of cigarette smoking history, then they are high risk and they have to be sent for screening. And other if the person is less than 50 years of age or less than 20 pack year history of smoking, then they are considered low risk. No screening is recommended for them. But I think other panelists may be having better suggestion regarding screening, because it is
Well said,
also
Anirudh.
very
Beautifully
important.
explained. Yeah, you well said about this no lung cancer screening and tobacco. Tobacco is one of the risk factors. Apart from the age criteria, age is 50 plus, asymptomatic individuals. So you have to screen. Which people you have to screen with a low dose CT scan? Clearly mentioned about the 20 years back cigarette history and all. Thank you. So we'll move on to Dr. Sonal ji. So, how to counsel the patient with the tobacco habits? Already mentioned in detail about that, 5 A's and 5 R's about that. So, Sonalji, can you throw some light on the how to counsel the patients in your clinic, in your tobacco cessation clinic?
Just a second. Just a second.
Yeah,
Sir, yes, sir. Yes, you're audible. There was a difficulty. Can you please repeat the question?
yeah. Question is how to counsel the patient with a tobacco habit. Already you described in your presentation about the 5 A's and 5 R's.
Yes, sir. Yes, sir. Yes. Yes, sir. So I need to elaborate on them.
Yeah, just can you throw some light on that? Yeah.
Yes, sir. Yes, sir. So basically, psychosocial support is very important. First of all, psycho and social means like psychology of the patient itself and the social support he is actually getting. So nowadays there is no difference between the lower and I think there is some difference. Like BD is more common in the lower socioeconomic status, and in upper, so of course they will go for higher branded of cigarettes and all. But the thing is the same. So primarily we practice three or four kind of therapy. First being the behavioral therapy for them. Behavioral therapy means they identify the triggers. You know, what is exactly happening? Is there any stress which is leading to the same situation? Whether the environment itself is promoting them, or there is some temptations regarding the same, like they are their friend circle and all. So, and we positively motivate them to be in such a circle that discourage their smoking, or at least change their setting. Suppose 10 days he is abstinent from cigarette, the person, and goes to a party or any social gathering, and the other friends are promoting, chalo ek cigarette lene se nothing will happen. So that will of course again lead to relapse for the patient. So such and he should be very clear that okay, I have set a quit date for myself, he or she. So this is suppose 15th August is my quit date. So he will be surrounded by a circle which will encourage him, not like discourage them to okay. So that is one more thing that is called as motivational enhancement therapy. And then cognitive therapy, of course, is important. That their own cognition, what is the exact situation in which is leading them to more and more smoking. So here, in my personal experience, the people who are like already stressed, they are for some or the other relaxation technique, they start smoking, and like male is smoking, then their female friends also, okay, why we cannot smoke? We are also, equal in right and everything. So in early age, in 20, as rightly said by the doctor, which leads to infertility and all. So they will, कि हम सब एक साथ smoke करेंगे and whatever the thing is. But then the later part, withdrawal part and all, is very dangerous. Withdrawal में what will happen, that they start having all those anxiety and all, and panic attack, and lower concentration and lower frustration tolerance. So I think behavioral skill training, to summarize it, behavioral therapy, skill training and relapse prevention is the major changes we can do as a psychiatrist. And also we know about 5A and 5Rs, and then 5Ds are also there, which are like, how to, I'll come to that question in the later part. Like, if I have some time, then I can elaborate that 5D are to delay the smoking, delay the urge. First D is that, then distract yourself from that situation. That is the second D. Then comes drinking water. Drink plenty of water whenever the craving occurs. Then we also advocate deep breathing exercises for them. That is the fourth D. And then fifth D is the discuss the situation in which you are ending up smoking again. So that is the fifth D.
Fantastic, Dr. Sonalji.
Yes, sir.
Go to the patient using the behavior therapy is one of the important counseling aspects. We explain detail about so we have to motivate the patient. So 5A's methodology and 5R's and 5D's. So wonderfully explained. Thank you, Sonal.
Thank you.
We move on to Dr. Gagan about the tobacco cessation clinic. So in our hospital, we have tobacco cessation clinic and programs. So what about in your center? So can you throw some light on how to set up a tobacco cessation clinic?
Yeah, actually, tobacco cessation clinic was basically an initiative by WHO and the Health Ministry of India to curtail the use of tobacco among the population. This was the basic use. It was started in 2002 with almost 13 centers running all over India in the major cities. Then it went on increasing, and by 2005 we got 18 centers, 15 we got 18 centers, and thus it was renamed as a tobacco cessation clinics. So in that clinic, the purpose of this clinic was to offer support to those patients in the form of behavioral counseling, medication, and nicotine replacement therapy. Then NIMHANS is basically a nodal center of all these centers. It also offers twice weekly OPD to all such patients, persons in the form of expert advice, consultation, and behavioral counseling, along with other drugs also. And then we also have a National Tobacco Control Program that is running well, and that is doing the purpose of information, education, and counseling, and also trying to educate the patient, educate the population, and run a propaganda to avoid smoking, to quit smoking. So this was the main purpose of tobacco cessation clinic that is coming up slow by slow, and every state is adopting it in a somehow manner. We also have certain de-addiction centers run by the state governments, and we are also having people and taking advantage of that.
Thank you, Gagan, for this wonderful explanation about the tobacco cessation clinic in various places, how to set up and all. The team involves the physician, either oncologist. In our center, pulmonologist, we take care in our center. Other center, the oncologist lead the tobacco cessation clinic, and depends on the hospital facilities. So physician in charge of the tobacco cessation clinic, the pulmonologist or psychologist or psychiatrist. So they take it. Psychology role is very, very important. Apart from this, we have a counselor and other stuff to explain about the hazards of smoking and etc. So we have to counsel the patient properly. Thank you. So over to Dr. Sonalji, may I ask one question regarding the nicotine replacement treatment? What are the substances we are using, like nicogam and nicotine patch and spray, inhaler? So what is your practice? What is your advice about the dosages and the other things and all? NRT, nicotine replacement treatment. Sonalji.
Yes, sir. So nicotine replacement therapy is like, supplying lesser and lesser amount of nicotine through indirectly, which is less harmful, so that the lungs is not getting affected and the oral cancer is delayed. So delayed, or it can be prevented. So it is available, of course, in the form of lozenges, gums, over-the-counter preparations are also there. Also, there are nasal sprays and most of them are available in India. Some are still not available in India. So in my clinical practice, I prefer lozenges because gums, anyways, they are getting it over the counter. So usually they come up saying to like, we have already taken so many Nicotex, nothing has helped. So what can we do? So depending upon the number of cigarette they are consuming, either it is more than 9 or 10, half a packet, then we start with 2 milligram, 4 milligram. Initially I start with 2 milligram BD. That lozenges, of course, they are available in many forms, jelly forms also. And as I told in my presentation, that how to actually use them. And we also consider patches. Patches are, of course, once a daily preparation, which also help them in the withdrawal and the craving part, which they can place them ideally most effective being the shoulder part. Here we can place, or the neck part also, and sometimes the trunk and abdomen can also be used. The only side effect which is being reported is some rashes, which is also temporary, and the solution being changing the location of the patches. uh, then comes the nasal spray form also, depending upon the number of the cigarette the person is consuming, and deciding the number of the this thing vape spray given to them. So these are, shall I also speak regarding bupropion and vernicillin now or later?
Our next speaker will speak on that. I'll ask
Yes,
next.
sir. So,
Thank you so much
yes, sir.
for this NRT, nicotine replacement treatment. Nice. The gum patches,
Yes, sir.
all these things are available. So we have to sometimes, what is your take on the monotherapy or combination therapy? Do you use only nicotine replacement along with other medications? I'll come to the questions to Dr. Bansal. Bansal will answer. After that, we'll have a monotherapy is better or combination therapy. So I'll ask. A question to Dr. Bansal, Abhi Bansal. Non-nicotine replacement treatment like oral tablets for tobacco cessation. What are the tablets currently available for the tobacco cessation? Dr. Bansal.
I think Dr. Shukla has already mentioned that in her presentation. So she had spoken about bupropion, which is an antidepressant. So that is available, that is easily available. And I personally started a more conservative dose at 150 mg and then gradually make it twice a day. If a dose is required higher than that, then I'm very much comfortable referring the patient to my psychiatric friends, because they would be the ones to better monitor the adverse effects of some oral dryness and headache, which is what we normally observe. As far as varenicline is concerned, a couple of years back before COVID, Champix or Chantix, which were the two commercially available brands, were easily available. A lot of success was achieved with it. Patients had, in my practice, about 20 to 30% quitting rate was there with the use of these tablets. But post-COVID, the availability of Champix by Pfizer has gone down. It's not available in India. We do have a couple of local brands which are available online and at some places, some generic brands, but it's the lack of continuity which hampers me to prescribe this as of now. If it's available today, it may not be available tomorrow. So that is something which is a concern with varenicline, although it's I would say a much easier drug to use, lesser side effects, more potent because it directly acts at the nicotine receptor. So the craving component part, which is the main concern, is elevated. And I'll probably take a question out of Dr. Sonal's thing as well, that I personally prefer nicotine patch plus therapy because the maximum success is achieved with a patch plus or a combination therapy. So whether it could be a patch plus a gum or a patch plus lozenge, because the patch is going to give them a sustained level of nicotine throughout the day, and the lozenge or the gum is going to take care of that initial craving. So this is what I currently practice, sir.
Same here.
With the bupropion or vernicillin. So yeah, vernicillin available is nowadays is getting difficult to only the Champix or Chantix not available to the places, but local brands are available. Some of we are using the online purchase and all. So combination therapy is most useful. Thank you, Bansal, for this wonderful. Coming to Dr. Anirudh, so strategies to prevent tobacco smoking. So what are the strategies to know how to stop smoking, how to prevent this habit of smoking. So over to Dr. Anirudh. Anirudh, yeah.
So this question, sir, seems yes, sir. Hello.
Yeah. Audible.
Sir, am I audible?
Audible. Go ahead.
Yes, sir. Yes, this question, sir, seems to be like more of a question which has to be asked to the government. What should be the steps to quit smoking? So, what as a physician we can do to prevent smoking that the patient does not start is that whoever patients who are coming to our OPD, we can like educate them that smoking cessation and maintenance, that is different, abstinence is different. Prevention of smoking is like we can just educate people whoever are coming to our OPDs, and we can put up some posters in our clinic, just like we are having posters for tuberculosis awareness and not to discriminate against TB patients. So we can do that. Apart from that, I think, sir, government has to take some steps, just like in case of tuberculosis, which is called as the essence of tuberculosis. Basic principle is the administrative will and political commitment. So, so if there is administrative will and political commitment to the executive and the legislature, they are like they should take more steps. Which what I would suggest to them is that like they should stop ban all the kind of advertisement. They should like uh, reduce the production also, the right from the where these tobacco products are being produced. They should try to stop the production also, cut down on production. As compared to our Indian society, in my area, it's like deeply embedded in society, this tradition. यहाँ here we what we say is क्या कहते हैं यहाँ पे हुक्का पानी बंद कर दिया जाए, means so साथ that nobody should socialize with them. हुक्का नहीं लेना, इनके साथ पानी नहीं पीना. Don't drink and don't smoke hookah with them. So already it's so much deeply embedded in our society. Whenever some people sit together, they offer each other BD in my part of the country. So it's like public awareness that we have to do. The government has also has to take steps. Although the smoking tradition has decreased from earlier, it has reduced a lot by itself by the government campaigns and by physicians, nursing staff. They are like healthcare workers who are explaining the harmful effects of the smoking and use of oral tobacco and other things. But what I can do, what we can do as physicians or doctors is like not much. This is my take on this topic.
Thank you, Anirudh, for this wonderful update on how to prevent tobacco smoking. There are several strategies. As a doctor point of view, we have to explain to the patient, family, and all. And patient has some responsibility, family has the responsibility, and the policy makers, and so on. There are a lot of people, media people also plays a major role in preventing this kind of tobacco cessation program. So coming to the question to Dr. Sonal ji. Sonal ma'am, so we are seeing in a practical way, a lot of patients, 6 months 1 year, they follow regularly, they stop smoking with the medications and all. Again, 6 months 1 year later, doctor, I started smoking weekly 2-3 cigarettes. Now it's slightly increasing. Whether I restart the nicotine replacement gum or patch or the tablet, they're asking. So how to tackle this kind of a relapse of smoking habit? Sonal, relapse of.
Yes. So relapse of nicotine is quite common. Most of them in my practice, they'll end up in smoking again. So they'll say that, okay, we have reduced it, like not completely stopped it. Like after 6 months of fully stopping it, we consider the positive biological as beneficiary effect which actually starts. But when one day again start, then the same thing goes on. So they'll say, now we were having like 10 cigarette, now it is just 5 cigarette, and next month we are going to completely quit. That next month never comes. So again, they'll ask us ki whether with your medication can I still smoke cigarette, whether it will decrease the efficacy of your drug per se. So I, being a psychiatrist, I cannot, of course, encourage smoking, but I tell them that any of the psychotropic agent or whatever will interact with this your enzyme cytochrome P450, as we all know, is most notorious for all the psychotropic agent, and it will decrease your efficacy. If you, even if you are coming for anxiety issue, your anxiety will rise up. If you are in depressed mood, you will become from moderate to severely depressed, even the suicidal also. So and you would even not know. And of course, weight gain and weight loss is very common with that. So how to prevent is like we avoid any temptations as such. Ki, like in the surrounding, of course, social संगत का असर पड़ता है is a very पुराना कहावत of our India culture. So संगत बदलो, change your friends. It is not very easy, but at least they can avoid such people. And stress, of course, should be taken care of. Stress means like proper eating habit. We all know that drinking water is so essential. Still, we all don't drink that much water. So doctor per se also drink very less water, which I have observed. So leading to again more stress and leading to cigarette smoking. And of course, healthy food habit is important. So no pizza, burger, momos, or Chinese for them for few months at least. Till they control that temptation, how will they control smoking? So relaxation technique, of course, is important. Yoga, meditation, at least deep breathing exercise like and shavasana and some anulom vilom exercise. Yoga, meditation is strongly encouraged by me. And if like they are not pursuing their hobbies, like somebody likes to paint or dance or join Zumba, then I always encourage a positive environment for them. Yeah, these are all the relapse prevention technique which I advocate. Yeah.
Thank you, Sonal, for this wonderful answer for this, how to tackle the relapse of smoking habits. Now we'll take some questions from the chat box, dedicated questions. Question from Tamil Nadu, Dr. Rangarajan Ambaram, Coimbatore. What is your opinion on snuff and its equal to cigarettes? Yeah, anyone? Snuff and cigarettes, is it equal or is it a bad effect? They're asking. Gaganji, you can answer this question. Snuff powder as well as this is whether is equal to cigarettes. Asking. Gagan?
It's not equal to cigarette.
Correct.
I snuff like it is snuffing is like directly that nicotine is going inside the snuffing and doing like that. And nicotine, of course, there is a gradual exposure of the nicotine so that the blood level of nicotine increases, I think, gradually, and snuffing mean more toxic to the nasal mucosa itself.
The question from Dr. Dinesh, Rajasthan, Bilbara. Is Varenicline available in the market? Earlier we discussed Varenicline previously available as Champix or Chantix and all. Now it's not available. So very rarely available.
It's available. It's available.
Yeah, available. Your place available, ma'am? Okay.
Yes, yes.
Right. Our place is very difficult to get the Varenicline chemical, the brand and all. Other local brands we are using that. So okay. Other questions. Dr. Yogish from Tamil Nadu, Chennai. Is vaping safer than cigarette smoking? Already we discussed during our panel our discussion. So
we already said that.
Yeah, Gaganji.
No, vaping is vaping is not at all advocated. Though it is slightly lesser than cigarette, but it is not advocated for health reasons.
Fine.
Already discussed this.
Okay. One more question from chat box. Dr. Krishnamurthy from Tamil Nadu, Tiruchirappalli, is asking question. Pharmacological updates in quitting smoking. Anyone volunteer?
I think nicotine replacement therapy is everyone is advocating that. That's the need of the hour, sir. It's more easily available. It's available across the country. NRT, that's a patch plus therapy. Drugs, sometimes patients are not that receptive to go on medication. When you tell them that they need to be on certain medication, they probably Google about them. And when you tell them that it's probably an antidepressant, the apprehension probably is a bit higher. So I think nicotine replacement therapy is something that's the pharmacological advancement, maybe different delivery mechanisms and delivery methods of nicotine which is available
In the form of patches, gum, lozenges, or nicotine replacement therapy is
Yes.
definitely the first line
Yes.
therapy to be advocated after behavioral counseling and other things. In pharmacological, then we can go on drugs like bupropion and varenicline, as discussed by all of us in our talks already. We have sent the clear messages regarding this.
Yeah. Rangaraj is asked one more question. What is the definition of casual smoking? What amount of cigarettes or BD he should take to be in a safe zone?
Yes.
Is considered safe zone. We are here to say
there is no safe
smoking.
zone.
Our topic of discussion today is no smoking. So we don't advocate any such things.
Passive smoking is causing detrimental effects on health.
Yes. That Rangaraj again is asking, what is the role of herbal cigarettes? Have you heard any herbal cigarettes in practice?
We haven't heard of any herbal cigarettes, but local in the form of tobacco and any form of tobacco consumption in the local way or other ways. That is what people are talking about. They have already
actually herbal cigarettes are all ganja cigarettes, I think.
Yeah,
they contain cannabinoids. Yeah, and that is a simple marketing strategy calling them herbal. There is nothing like it. They all contain cannabis.
Yeah. E-cigarette was also promoted early for the same reason, and later on everything came out to be.
Some of them are flavored menthol and other things. And I remember from hostel days, there used to be a brand called, I don't know whether it still exists, Gudam Garam. So Gudam Garam is very popular in
Indonesian brand,
and Malaysia. Indonesia,
yes.
Exactly. So some people used to have that, thinking that it is less.
But different name of tobacco. Nicotine being said in different brand names that comes from different parts of the country. Ultimate pleasure the person gets is from nicotine.
But it's still an inhalation injury, sir. So it's going to cause you some harm. Although it may have less chemicals, it still has chemicals. It may take slower than a cigarette to cause cancer or COPD, but it's still going to cause it eventually in the long run. That's how your addiction starts.
Another question from Dr. Yadav from Uttar Pradesh, Lucknow. Please tell some carcinogenic compounds in the tobacco smoke. Yeah, already we mentioned in the presentation. Lot of chemicals, that is mainly the nitrosamines, polycyclic hydrocarbons, and then nicotine predominantly is addictive habit. There are a lot of substances A to Z. There are more than 4,000 chemicals. In this, more than 70 chemicals are carcinogenic potentials, causing all type of cancers.
Yes.
Other question from Karnataka, Dr. Manjula from Mysore. Explain in detail about the pharmacotherapy of tobacco cessation. So already we mentioned about that. That is a nicotine replacement treatment. Apart from counseling, there is a nicotine replacement therapy using the nicocam and nicopatch commonly we used in practice. Along with that, non-nicotine treatment, oral tablets, bupropion 150 milligram twice daily for 2 to 3 months period, and follow very carefully. And varenicline also available in majority of the place. Some places not available. So combination therapies are very useful to control, to prevent relapse of the treatment. That is one. Another question from Damodaran from Tamil Nadu. Very difficult to convince the patient, even 1% people not taking advice. Yeah, needs a lot of counseling. Every patient visit to the clinic, you spend 2-3 minutes more to the patient and patient friend and family. Such a way that then only we can know. You tell about all the smoking hazards, what are the health systems, and in show with the pictures, then only they fear about the cancer, heart attack, sudden death, and all. Then only slowly it will take time. So counseling plays a major role in a tobacco cessation.
I think, sir, there is also a role of motivational interviewing. So motivational interviewing is a very, very important thing, and I think they should actually try that.
Right, motivational.
And
Sir, in USA, there is it's about their protocol. If the patient has any problem, they have to ask about one smoking and another thing is about drinking. Even if the patient is coming for entirely another different problem, but they have to ask about it. And if they find that the patient is having any of these addictions, then they have to counsel about them. So it's not just about those people who are coming with respiratory complaints, but just to even to find out from that whether they are addicted to anything or not.
Another question from Dr. Sri Shyam. Karnataka. A patient approached with a history of chronic addiction to tobacco chewing. He wants to discontinue or stop. What are the alternatives or methods of abstinence? Sonalji?
Yes. So the alternative method of abstinence. You wanted to ask.
I discussed in my presentation, there are certain alternative therapies like yoga, meditation, and other forms of relaxation techniques that can be avoided.
Yes,
But
yes.
these are still less documented, and more research and studies are still needed to bring them into mainstream life. So
And
the
also,
behavioral therapy that is
yeah.
discussed by Dr. Sonal, psychosocial support behavioral therapy can be individualized from person to person, and this is the only mode of basically going on with this.
Aversion technique is also there. So, so there aversion technique is like, suppose the person is like continuously smoking double the amount of cigarette, so 20 cigarette in like less than 1 hour or something, which cause them aversion. So they have nausea, vomiting, and like that. So then they gradually, the positive pleasurable effect of the nicotine gradually decreases. So the patient develop unpleasant feeling by consuming more and more amount of cigarette. Initially I know it is harmful, but gradually they develop very strong aversion. And second thing is nicotine fading. Nicotine fading is also used, that is like tapering the cigarette, the amount of cigarette the person is using, and using less nicotinic, less nicotine containing cigarettes. That is known as fading. So these are two things which I would like to add.
Technology. And one more question from from Dr. Chatterjee, Maharashtra, Mumbai. What is the flow chart? First, I guess there should be a strong desire to stop, and then what do you advise? That is Nico gum, Nico patch, lozenges, other thing. We start pharmac treatment directly, which many times patient want. This is a question like Dr. Chatterjee is asking. So usually, in a case of treatment modality, apart from the counseling, we start with the nicotine replacement treatment, either Nico gum or Nico patch. Depends on the patient's number of cigarette smoking habits, and we will see the patient how this able to stop or not, or we can add the oral treatment like bupropion or varenicline. So combination therapy will work nicely for 2 to 3 months period. Then maintain with oral Nico gum or the patch. So this way we manage the patient. So any other opinion from the panelists, you can update.
I think positive reinforcement,
yes.
keeping a check on the patient, ensuring that the patient is complying with what we are telling, and having a caregiver also monitor the patient. Because often psychological support from the partner or a family member is equally important. And when you have that urge to smoke or the urge to chew tobacco, probably the family member at that point of time can be a moral support and tell you that no, you're doing so well, just keep doing it. So I think that is equally important.
Yeah. Family support and friend support are very important for this kind of thing. Again, Dr. Chatterjee sir is asking to avoid a second-hand smoke from a smoker in an open space. Is there any minimum distance which can be maintained to minimize inhaling the second-hand smoke? Gagan ji, any other answer? Is there any distance between to prevent second-hand smoke?
I think so. I mean, sometimes you can just smell smoke from miles away. It's still circulating in the air. Yes. So although the person may have smoked and walked away, but when you cross that path, the compounds are going to be still dispersed in the atmosphere over there. So you need to be away from where the person or where the smoke is actually. And if you're going to go to play,
once we have started talking of third, just now our panelists discussed the third
smoke.
So how can you now distance is no more important, because all those particles are already there that can be cause third. So we have come to a next stage or level of smoking cessation now.
Question from Dr. Rangarajan from Tamil Nadu. So, what is the effect of smoking on sexual performance? Smoking and sex. Animesh, Bansal?
Sir, I think there have
Erectile
been reports
dysfunction,
about,
there have been cases reported.
Yeah, there have
It
been
reduces
reports
the
of erectile
libido.
dysfunction, libido,
It
exactly.
reduces the libido, causes erectile dysfunction, basically can involve and harm any and every part of the body, including your reproductive organ. So infertility and reduced libido is known.
Absolutely.
It is in short term it is okay, it gives pleasure, but as discussed by our panelists, in long term it is causes infertility and other sexual health problems. So it is not recommended as a positive point of view. The smoking has a negative impact on sexual functions in a long term.
Again, there's from question from Dr. Jayaraman. What is the role of that already we addressed everything. Can I? Okay. Dr. Hemal is Maharashtra, Mumbai. Can you send me a recording? Yeah, definitely. We'll send all the recording in the YouTube. So coming Tuesday we'll upload as from the platform. Thank you. And one more question. So Dr. Tridip Chatterjee is asking hypnosis to help quitting. Dr. Sonal, hypnosis, hypnotics. Hypnosis.
Yes, sir. The hypnosis, of course, is it's a very fancy term for a psychiatrist. So, frankly speaking, I don't practice it, hypnosis, in my setting because it requires a lot of patience. Plus, a psychotherapist does it better. So it is done. It is a Freudian term. Sigmund Freud and neo-Freudians had also practiced it. So it is, of course, is a suggestion, as you know, that hypnotic suggestion also can be done with the help of ketamine and also thiopentone sodium in some amount. So hypnosis has a role, and many many psychiatrists and psychotherapists do advocate is as a form of nicotine cessation, and it has got positive benefits in the patient because usually mostly them are stressed, either anxious or depressed or having lot of personality disorder, attention seeking, picture avoidant personalities. So they all come up with that hypnotic suggestion very well, and with 6 to 8 sessions of hypnosis, quitting rate I think doubles. Like it almost like they are cigarette and nicotine free for more than 1 or 2 years. And of course follow up is very much required in those settings, like and if there is any trigger, then it should be taken care of, and the patient should be willing. Especially in the case of female patient, we should be very careful that some female attendant should be present during the whole session. Yeah, that is, yeah. I think I answered.
In one line, I would like to say hypnosis again comes under alternative therapies. And as I said, all alternative therapies lack documentation and rationale for this date. So still we have a long way, and we need some records and scientific evidence to all for this, which is
nobody gives the record for this hypnotic session. I think
that is scientific evidence is still lacking. So we as a doctors cannot recommend from our point of view to start all these things. So our treatment protocols remain the same.
Okay.
Yeah. Next we'll go on to Dr. Anirudh. Can you throw some light on this year theme of the World No Tobacco Day?
Yes, sir. Yes, sir. Sure. Sir, after the success of the No Smoking Day, WHO in 1988 started observing 31st May of every year as World No Tobacco Day. And this year the theme is protecting, as you have already mentioned, protecting children from tobacco industry interference. So as we all know that since the beginning itself, this tobacco industry people, they have been trying to glamorize the smoking and these use of tobacco, especially the cigars, cigarettes, pipes, to make them feel cool and to motivate more people to use them and to make the other people who are not using such products feel like they are inferior. They are spending a lot of money, a humongous amount of money to just make people think that smoking is really cool. And they pay a lot to media and advertisers, making different advertisements. So although the government and WHO have given a good fight against this, but still their target is to what the WHO is, the target is to like hooking the new generation. That they want to get the people addicted at a younger age. Already 30 about it has been estimated like about 37 million youths of 13 to 15 years of age are already using tobacco. So it's like the chain. If this they are looking the tobacco industry is looking forward for a lifetime of profit. If people at young age, if children, adolescents use at young age, they get addicted. Then about for a lifetime they are going to get addicted in some form or the other. So WHO and the governments, they are making effort to cut this chain. So if we produce a complete generation of young people who are free from use of this tobacco, who are actually aware of the harmful effects, and that they won't be in the things won't be in their control once they start using it. So we can so if we can cut this link of the chain, then their children, the next generation, they will be educating their next generation. So the overall tobacco use will decrease a lot. So this is what the WHO and other people are doing. We can also contribute in our capacity. The governments can contribute. We can, like as we are conducting this CCI webinar, this is also one of the most important.
Thank you, Anirudh, for this wonderful insight about this theme of the World Tobacco Day, protecting children of tobacco industry interference. Thank you. Over to Dr. Gagan ji. Can you throw some light on the statistics of India about the tobacco habits and types and other things and all, briefly? Yeah.
Very surprisingly, you will be surprised to know that there are currently 267 million tobacco users in India, making it the country with the second largest number of tobacco users in the world. Out of these, approximately 100 million people ages 15 and older currently smoke tobacco, and approximately 200 million people aged 15 and older currently are under the smokeless tobacco group. So tobacco is estimated to account for nearly 1.35 million deaths. 1.35 million deaths, which is really a quite number. And you will be surprised to know it causes almost 27% of all cancers in India, as per the data received last from 2020. So this is a drastic data that I have from these tobacco users, and we need definitely to aggressively step up the program of tobacco cessation and quitting tobacco.
Thank you, Gagan, for this wonderful insight about the statistics. We look behind the statistics and all, so nicely thrown light on this. Thank you. Coming to Dr. Sonal ji, what is the this thing? Incidence of Indian female tobacco habits. So day by day we are seeing a lot of female populations. I'm sitting in my OPDs, a lot of patients know the 25 to 30 age group, they're coming. I ask the smoking history. Some of the females, why doctor, you're asking smoking to me? Some of the young women there, yes, doctor, I used to smoke weekly. So what is the incidence of Indian female tobacco habits as per your experience, Sonalji?
So as per Indian clinical data, it is actually 48% of the males as compared to 20% in the female population. That's what statistics says. So of course you said it right that many females get offended that how come you are asking about cigarette. But what I have seen in like today's population, especially the teenagers and the 20 to 30 age group, it is quite increasing actually. They have many have that fancy cigarettes which have got many flavors, and also as said by Dr. Animesh, there are some hookah kind of bar going on which give them flavored thing, and then they enjoy that smoke which come per se, and they usually combine it with alcohol as well, so which is more detrimental to the overall physical and mental well-being. So of course that is increasing in the female as well, and a lot of issues then regarding the reproductive and infertility, as said by Dr. Jain, that leading to polycystic ovarian syndrome, and hypothyroidism has also been present. And of course, in our society also, Gudako and Khani, and in the lower socioeconomic class, especially the labor class of the females, who are unaware of their carcinogenic effects, and because their husbands are already dependent on it, so while doing the hard work, they give it as a reason that we are doing so much hard work. Then they combine it with, chuna, which is like, calcium, and then along with that they consume, and this and that is very harmful for the, and lot of oral cancer have been reported in the females as well. Yes.
Thank you, Sonal.
Yes, yes.
Coming to Dr. Animesh, regarding the tobacco control, advice to the policy makers regarding tobacco control. What is advice you going to give to the government as a policy makers, politicians about the tobacco control? Animesh.
Very, very interesting, sir. Very important. Thank you. But before that, I want to stand corrected, and thanks to Dr. Gunjan also for giving those statistics. So the smokeless seems to be double the what he just narrated numbers, and I did a little searching also while the others were speaking. So actually, the smokeless is higher in India, in fact, compared to the smoked form. So I stand corrected, as I had said the reverse earlier. Coming to the advice that you've asked. So, sir, we know that, and in fact, I used to see the budget as a child also when I used to see it with my dad. And so every year there is a hike in price, which is one of the strategies which is used by the government to dissuade people from buying, but we know very well that it has not really worked. But of course, that is one of the strategies, taxes and hike of price and things like that. But more than that, what is also important is we have a COTPA Act. So again, that limits the availability of tobacco products around the educational institutions.
Yes.
Around the educational institutions, 100 each. And I think that is something which needs to be taken care of. Then also, we should try and see to it that the availability is also curtailed and the number of products are also reduced. Easier said than done, but yes, I think that's something. And advertisements. Now, at one time, if you see, a lot of these advertisements were banned. The display of the shop, those name boards and all will not have. But again, slowly we have seen that is mushrooming. So I think something like that has to be again curtailed. We have to see to it that that happens. But more importantly, I also want to see to it that in many other arenas like sports or movies, we should have less depiction, because these can condition the influence on the youth. And this year being the theme that children have to be protected, because these tobacco lobbies are very, very, very smart. Interestingly, I had reviewed a book by Simon Chapman years back about tobacco control and cessation related book. So it talked about a lot of things, including in the vicinity in Thailand and other places, and we were lagging behind. Of course, we have made tremendous strides and taken a lot of efforts. But I think one is, I would suggest that enforcement. The other thing is make it easier and accessible and affordable for people to access the tobacco cessation treatment. I think that is something, and popularize that. And also to make it easier to complain and take action if at all there is a violation, which I think personally also once or twice I've experienced that it's not as easy, or even if you go and complain, not much action or harsh measure is taken. So I think that is also important, because if somebody is facing, like if I'm traveling in a train and if I want to complain, where do I complain? What punishment the other person who's doing or offending me is going to have? So these kind of things have to be taken care of. And I would like to take a little deviation. The city of Indore, I think we know it for multiple reasons, including cuisine, but it's also known for being 7 times consecutively the cleanest city in India. And why has it happened? I have seen the transformation, because that's my sasural. So I have seen that. I didn't believe it when I heard that, but I've seen it. So basically what I've seen is now there is a people's behavior has changed. It's not legislation, it's not any other thing, but people's behavior has changed. And that has changed as a collective thing. So I think that's something is required here. See, whatever whatever we do, the legislations, the taxation, whatever, and as doctors we can motivate, but finally it is the people, the onus is on the people, and if they realize and if they change, I think that's going to change the whole thing. So I think the government has to take steps to see to it that it becomes a people's movement and not a half-hearted thing, but also something which is done with the motivation and also the efforts to see to it that we become tobacco free. So that's what I would suggest, sir.
Animesh, a lot of points for the policymakers regarding tobacco control. Thank you very much for that. And coming to the Dr. Bansal, what purpose the tobacco came in the, just about the historical perspective I'm asking Bansal. So what purpose and how the tobacco came into the world? Yeah.
So I think tobacco came 1500 or 1600 BC, and it was cultivated in Native America, and then gradually the spread has been throughout the world. You had Columbus in the 15th century, and Toledo spread it across the West Indies and India. And it was initially believed to be a magical drug for almost all ailments, right from nasal polyps to constipation to opening up the pores in the body. And then it became a trading material. It was preserved for special occasions. So all sorts of things have been conceptualized just to show that tobacco was supposedly a good product. Only towards the 20th century and a lot of the Framingham study, which told us about the adverse effects on the cardiac status with respect to tobacco consumption and lung cancer, has the awareness about the harmful effects been come into light. And as of now, there's no medicinal purpose or medicinal awareness or activity related to tobacco anymore. So it's all a harmful and a negative impact, which has over the period of 4,000 years culminated.
Thank you, Bansal, for the wonderful historical perspective of the tobacco. So now the time is 9:53. Almost will come to the conclusions. So wonderful. We have learned. I have learned a lot of things from you. Definitely is also a lot of take messages. Finally, I request each and every panelist to tell 1 minute about the final take messages. To start with Dr. Gaganji.
Thank you, sir. Thank you, Chess Council of India, for giving this opportunity for such a wonderful program. To conclude, I have already given you data that almost 267 million people are currently suffering, and India is the second largest user of tobacco in the world. With so much of data, nicotine addiction affects millions of individuals worldwide, and its impact on physical and mental health cannot be underestimated. The addictive properties of nicotine make it a very daunting task for us to help people quit smoking in spite of several attempts. Still, the right form of support and guidance from family, friends, and co-workers can help in one's achievement and can go a long way in the form of psycho-educating yourself, identifying the trigger point, and making lifestyle changes, and reaching out for support and help from your family and friends whenever you need. These are the only final words from my side that can help you in quitting tobacco.
Wonderful, Dr. Gaganji.
Thank you so much.
Well done. May I request Dr. Sonal Shukla, you will take a message, ma'am.
Yes, sir. Thank you for this opportunity, and it was really nice interacting and listening to all you excellent speakers. From my side, the take-home message is like be a very a role model. Like doctors, when I see some patients to me, then they give the reason that our doctor themselves are drinking and smoking. So why are you actually advocating us not to do so? So I'm speechless. So the thing is, we should be the role model for the society, first of all, and secondly, feel free to come to a psychiatrist. Usually, from us, they are brought by the family member, like saying, "See, the boy wants or the girl wants to quit smoking," but as soon as they enter my chamber, they will say, "We are not mad. Why are we brought here?" So the awareness is slightly changing now. They are coming, like the teenagers are coming. Like recently, a girl who was just 21, she herself came with the mother being a maid, like she wants to quit cannabis. She's totally in dependence of cannabis. She's not eating, very irritable and all, but she started initially with the cigarette smoking as well, which gradually take a toll on her mental health. And then she started this cannabinoids and sometime also injectable form of this opioids. So multiple addiction is very common. So I would like the society to notice the slightest change in the behavior of the teenagers or the young adolescents, and then please feel free to come to the psychiatrist. Yeah. Thank you.
Thank you very much, Sonal, for wonderful conclusion take messages. Thank you. May I request Dr. Bansal, Avya Bansal, to take messages in this World No Tobacco Day.
So I think nicotine replacement therapy is going to be the future unless some magical drug comes into the play, and we must be more advocating with respect to nicotine replacement therapy rather than leaving up to the patient for sheer willpower. And also have a MDD kind of an approach like we do with all our other lung ailments. Have a counselor as well as a psychiatrist with a pulmonologist to help patients de-addict themselves from this harmful and toxic habit. So I think an MDD would be, why not? We do it in ILD and COPD and airway disorders. Why not in smoking cessation as well?
Yes. So we'll take messages, multidisciplinary approaches, definitely. Thank you very much. May I request Dr. Anirudh Saini, what's to take messages on this World No Tobacco Day?
So my take-home message is it's like very similar to Sonal madam, that I think the attitude of the society needs to change. Still, where I live, I am surrounded by people who still think that smoking is cool. Other forms of addiction are cool. And another thing is that I before this session I never thought about referring a patient to psychiatrist for smoking cessation. But as I can see, psychiatrist and Madam Sonal, they are doing wonderful job in helping patients quit smoking. So at least every smoker patient, he or she deserves at least to a psychiatrist who is actively in helping the patients, who is patients for smoking cessation. So I think one psychiatry reference should be done at least early in the process of quitting and abstinence.
Yeah, thank you, Anirudh. It's very well said about this role of psychologists and psychiatrists help, because it's a long run. We are seeing a lot of relapses. How many times we counsel ourselves? We have to refer the patients appropriately for the psychiatrist and psychologist. Counseling is very important. Well said. So, last but not the least, Dr. Animesh Jain, what's your take messages? Thank you.
Thank you, sir. I'll just quickly narrate one instance and one actual story. So we have a faculty in Manipal Institute of Technology, sir. So he actually was into smoking and he quit smoking. And how did he do that? So one fine day he decided, and then he got into this cycling habit. And he started cycling, and then that has really helped him. And now he has cycled in Himalayas, he's cycled in Europe, he's cycled in Iceland, he's cycled in multiple places. Now he has a course, and he takes youth for these different things and camps. And I think it's at least more than 7-8 years or so I have known him that he's quit, and he's become a motivator. He puts up blogs and Facebook posts and other things. So I think we need such role models as well, that it is possible. Now, to come to the concluding message from my side, I would like to say that, see, there is no safe way to use tobacco, whether it's smoked, inhaled, sniffed, chewed, whatever, sucked, whatever, or whether it is flavored or mixed with something or reduced in ingredients, whatever, it's not safe. So that's one thing which we have to remember. There is no safe way to use tobacco. So creating a tobacco-free world is everyone's responsibility. We all are stakeholders. We all have to play our part. And I would like to appeal to all our colleagues, healthcare professionals, that whenever we come across somebody, try to elicit a history of tobacco consumption, smoking, and also look for some signs of tobacco consumption or tobacco use. Talk about it, motivate them to cease smoking or consume tobacco. And as Dr. Sonal also said, I have also been very strong advocate of practice what you preach, be a role model. Yes. I've written about this long back in a journal. So I think that's very important, because we should not get into a situation, hey doc, but don't you smoke? Then how can you tell me to smoke and quit smoking? So I think that's very important. So thank you.
Fantastic, Animesh. Wonderful take messages. I thank all the panelists, the wonderful take messages and wonderful lot of points. I learned so many things. Definitely delegates also learned so many things. I thank you, Sonal Shukla, Dr. Anirudh Saini, Ranchi, Avya Bansal, and Dr. Animesh Jain for this wonderful insight on tobacco, World Tobacco Day. So finally, my concluding remarks and word of thanks. So make every day World No Tobacco Day. Why May 31st alone? This is our responsibility. So we are stakeholders. We take care of our patients. Through a medical point of view, as a medical point of view, we see every patient, those who are having smoking habits, we'll spend additional 2-3 minutes more and properly, refer the patient for counseling, and whether the patient requires, drug therapy, pharmacotherapy, like nicotine replacement or non-nicotine replacement. So we have to, consistently, we have to, a lot of strategies for 5 A's and 5 R's and 5 D's, a lot of things we have to apply to the patient each and every visit. Spend 2 more minutes, those who are having the smoking habits. So smoking is a leading preventable cause. It's a disease. It's a preventable cause of disease and premature deaths. There are a lot of major diseases, death due to the tobacco smoke, directly linked with the heart attack, stroke, lung attack, COPD exacerbation. We call it a lung attack, and the cancers, head to foot, all the cancers. So such a hazards, that is the enemy we are dealing. So we are having fight against this enemy in the human mankind. So we have to fight, and we have to do the combinedly take a decision with the medical team and policymakers and public. Everybody should take, and we have to tobacco-free future. This is our aim behind this World No Tobacco Day. So with this, I thank you very much, all the panelists. I thank you, our CCI, under the captainship of Dr. Krishna sir, and all the leaders, Dr. Shivani Swami and the Dr. Amitandani, all the stalwarts here, Dr. Rajadar, and all the governors. Thank you very much for this wonderful opportunity to spread across the knowledge into various places. So thank you all the delegates. So we meet next Thursday, and welcome to join our physical conference CCI Chalo Kashmir. So next Saturday and Sunday. So we'll meet again Thursday evening webinar. Thank you all. So long live CCI. Thank you very much. Good night.
Thank you, Dr. Jayaraman. Thank you. Thank you so much.
Thank you.
Thank you, everyone.